by, listen, I've already, to the few of the first people there, just explained what the idea behind this is. It's just a little bit of a session where we try and get as many people defending their thesis, essentially, as it's going to happen in the Viva. Well, is the Viva's next week, I think, isn't it? Or it's coming up soon, yeah. So the idea being is that you're going to submit your formulation. Your formulation's already pre-prepared. Then you're going to be asked questions and expected to provide kind of reasonable, defendable, succinct responses that show the degree of thinking, understanding, and that's really comprehensive. And it's just getting a chance to answer the questions, be critiqued on it, and then have some ideas of what I think you should have in your answers. And this, what I would say about this, I kind of caveat it, is to say that, are you able to see that? I have your faces in front of the slide. It's not obscured for you, no?
No, we can see it.
Okay, cool.
I can see it at least.
Well, so I'm not an examiner on the course, and I haven't marked students in real life, but I have discussed this kind of extensively with Paul about what the idea of the course is, and particularly the idea of the Viva is. And listen, that psychiatry is complex and formulation is a best understanding, and so we might not necessarily agree on some of the facts or some of the approaches that we discuss. It's more about having a reasonable, safe approach and thinking process. So even it's not about taking what we discussed today and parroting it. It's about coming away and taking your formulation, your patient, and trying to put some sort of structure on the answers for questions that you're going to be asked. For the general principles of formulating, we're not really going to be you're going to be reading out your formulation. I'm not going to be critiquing it too much. But what I would say is that these are available on the Moodle, and I think that these are a good, solid option for preparing your formulation. They're short, they're sweet, they're to the point, and they'll give you a good structure as to how your formulation is supposed to be. I think whenever you're preparing for the Viva, I think just remember that this is your patient. And I think that above all, coming across that you're thinking about this person in a degree of depth that you can do. I mean, you're going to know this person more than the examiner, and you're pretty much doctors and providing reasonable your own reasonably creatively thought out answers to how you would manage this sort of person. You've got time to prepare, so have a justified and defendable and reasonably detailed idea in your own mind that reflects what you really feel and know, and practice it. Practice answering questions about certain aspects of this person, and even having a core answer to these questions that is you've kind of learned off a little bit, so that you're ticking all the boxes, I guess. So, is there anyone who would be willing to volunteer? Hands are flying up. Okay, so I might just pick. And what I'd like you to do is just to let's read out your formulation very briefly, and I'm just going to ask you a question, and I'd like you to give an answer to it. Can I suggest? Listen, is it Lucy? You're the first person that popped up onto my screen, so I apologize for that. Do you have something prepared that you feel you might be able to just read out quickly?
Yeah, I'll just bring it up on my screen. Cool, so should I just read it out? Oh. So I'll just read it out? Yeah, cool, thank you. Sorry, I was switching my different screens. Okay, so Mrs. T is a 75-year-old female who presented to hospital with low mood, irritability, anxiety, and abnormal signs on neurological examination, all on a background of long-standing bipolar affective disorder. The new neurological symptoms included tremor, stoop posture, shuffling gait, balance loss, and short-term memory problems. Mrs. T is interactive to those around her, but had reduced facial expression and appeared vacant. Her speech was slow and she occasionally lost train of thought mid-sentence during the interview. She was diagnosed with bipolar in her 40s, but experienced 2 prior depressive episodes. Throughout her illness, she has required admission to the psychiatric unit and has had several suicide attempts involving medication overdose during depressive episodes. She now takes several medications for her mental health and recently stopped lamotrigine under the supervision of a GP due to possible neurological side effects of this medication. She's had ongoing pain from polymyalgia and has previously had abnormal liver function tests, likely due to alcohol overuse. So Mrs. T was originally born in England, but her family migrated to Australia during her childhood. She reported that this move was quite difficult on the family. People were seasick on the voyage across, and then the family was shifted between different temporary accommodations before setting up their new home in Australia. Mrs. T stated that her family was dysfunctional. She believed her father suffered from post-traumatic stress disorder and bipolar disorder, indicating a possible genetic predisposition to developing a mental health disorder herself. She reported feeling unsafe in his presence as he was emotionally controlling. Her mother was partially deaf and rarely left the home. I wonder if this disruption in her early childhood and the unsupported home environment made her vulnerable to developing a mood disorder and also instilled some poor coping strategies to deal with anxiety due to poor role modeling by her parents. An example of this is Mrs. T's use of alcohol and clonazepam to manage anxiety. Another example was that she reportedly rushed into her first marriage in order to gain a supportive and welcoming family. This is likely another coping strategy to compensate for her dysfunctional childhood. Another predisposing factor for the current admission is Mrs. T's long-standing diagnosis of bipolar disorder. The illness has had a rocky course and she's had several admissions to inpatient psychiatric units and multiple suicide attempts. She now takes several medications and previous attempts to alter these medications have affected her mood stability. Thus, given her fluctuating illness course, there's always a risk of relapse and presentation for mania or a depressive episode. There appear to be several precipitating factors involved in the development of this current presentation. Her lamotrigine dose was stopped 1 month prior, and she has a belief that this medication is key to maintaining her mood. The degree of stress in her life has also increased recently. With the development of some neurological symptoms, she's worried about that she's developing Parkinson's disease or another neurodegenerative disorder. Furthermore, with the recent COVID-19 lockdown, she's had limited ability to partake in management strategies for anxiety, including regular swimming and socializing with friends. Consequently, she's been using alcohol and clonazepam as self-medication. Hence, the cessation of the lamotrigine mood stabilizer and the increased stresses in her life and increased alcohol use has likely precipitated the current low mood. I believe that the ongoing lack of clarity for her neurological symptoms and limited ability to access usual coping mechanisms is perpetuating her feelings of anxiety, which contributes to her lowered mood and feelings of irritability and frustration. This is further intensified by the reduction in the mood stabilizer medications and the use of alcohol. Fortunately, Mrs. T has an extensive supportive network, including friends and family who live close by to her. Her second husband, who she's been with for the last 40 years, understands her condition very well and acts as her primary support. And he manages her medications, and he also remains vigilant for early warning signs of an acute deterioration. Usually Mrs. T enjoys a busy social life. She enjoys swimming and walking, and she recognises that these are good for her health and to manage her anxiety. Also, in more recent times, she's worked as a mental health advocate and auditor for DHB Mental Health Services. So she's got quite special insight into the management of mental psychiatric health disorders and has acquired some quite good management strategies due to this. Yes, so Mrs. T demonstrates good insight into her current state. And so she was able to tell people that her mood was low and that she needed help. And when asked what we should do about this, she requested that her medication was restarted in order to manage her mood. So she had quite good insight, which is protective. that's my formulation.
Listen, I think that's very well laid out, and just briefly surmising that is that it's a good exploration temporally of the impact of biological, psychological, social, and then also what's precipitated things now. But can I ask you, please list your preferred and differential diagnosis and explain your reasoning.
Okay, so my preferred diagnosis is a depressive episode of bipolar disorder. I believe this is most likely given that she has a long history of bipolar affective disorder, which predisposes her to this. Also, there has been a recent cessation of lamotrigine, which is good to help manage depressive episodes. So her mood might have dropped secondary to that. And she also recognises that the low mood and irritability that she's been experiencing are early warning signs for her bipolar disorder.
Okay, and differential diagnosis?
So it could be unipolar depression as opposed to the bipolar. Also, there could be an underlying neurodegenerative disorder going on, given her history of heavy alcohol use and her age and some of the neurological symptoms that she's been describing. But she has some imaging of the brain, and this was mostly normal, which makes that less likely. She could have a disorder which is related to the alcohol misuse previously, but she doesn't have any symptoms of like ataxia or other syndromes that I would associate with that. And another differential considered is like a generalized anxiety disorder, but it appears that there's a bit more at play here. And then I would consider like a medical disorder, but she's had normal endocrine function and normal brain imaging, as mentioned.
Okay. Yeah. So listen, I think that's a good response insofar as that you've obviously thought about. You've got a very clear preferred diagnosis, and you've got very clear rationale for that. Insofar as that, she's got a background history, and there's been a change in medication. She's given you information that would suggest that this is similar to her pattern. I would specify what symptoms in particular fit the criteria for a major depressive episode in the context of bipolar depression or bipolar depression current episode depression, because you will just say, listen, these are the symptoms she has. It fits with that criteria. She's got a background. So I feel this best fits this. Okay, I think that you're on the right track there, but just being precise about its current symptomatology and why that fits into that diagnosis. You're definitely thinking along the right lines in terms of talking about organic conditions. So you've listed the possibility of some alcohol-related disorder. I'd be a bit more specific about that.
Yeah.
Because you're talking about ataxia there. What specific alcohol-related diagnosis could this presentation be? Because you're kind of getting at maybe it's a Wernicke's encephalopathy, which is a triad and is usually an acute finding.
Yeah.
Or Korsakoff's psychosis, which has got a slightly more affective component, which is a slightly different thing.
Yeah. Okay, cool.
Or that there can be like primary affective problems caused by alcohol use. So just have that really fleshed out and nice and crispy is what I'd say. I think also the possibility of I mean, do you think that it's reasonable to have a neurodegenerative disorder in your differential?
I mean, she's 75.
Yeah.
So it's always something you can consider.
Yeah.
And there's only so much we can see on, brain imaging grossly.
Yeah. But just did she have objective movement disorder? Just remind me.
She had objective memory problems mainly.
Yeah, okay.
And problems with cognition, and she had a tremor.
Okay, yeah. So being
Mm.
clear, saying, listen, that would be my differential because of this.
Oh, okay. Yeah.
I could investigate that further. But on balance, I think that it fits my preferred diagnosis because of this reason, you know?
Yeah. Cool.
And I think you're getting into the pathway of saying, you know, listen, how would I? The other thing I was going to ask is, so you've already talked about how you would refute or include some of those diagnoses. Is there anything else you'd like to do now to try and exclude your differential diagnoses?
I think formal cognitive testing is important, and seeing how this relates to previous tests done. I also wanted to inquire if she's had any like manic symptoms in relation to her bipolar disorder. And I need to get a collateral history from the husband to work out what's been going on.
Why is the presence of manic symptoms important?
I was thinking with the history of bipolar disorder, whether there's been any mania precipitating this or.
Yeah. I think that's very reasonable. I mean, like, I think that she's coming into this telling you she's an established diagnosis of bipolar.
Yeah.
If there was any, you know, if you had any uncertainty, you're dead right that collateral about manic episodes would be the clincher, wouldn't it?
Mm.
That would make it fit that pattern much better.
Yeah.
So I think you're definitely. I think that we'll just go through what my kind of suggestions for answering that question is.
Cool.
I think you're on the right track, but I think those other elements of being precise about the differentials, precise about why you might be including differentials, precise about why you'd be excluding or including is important. Mm-hmm. And I think for your preferred diagnosis, explaining exactly why that it fits that criteria is important as well. So what I'd say is have a confident preferred diagnosis and a justification, including how it matches the diagnostic criteria. And I would use the language used in manuals, because remember, you do have a bit of time between now and the Viva to go through these diagnostic criteria and say, she has this, she has this, she has this, she has this. Mm-hmm. And what aspects of the overall presentation, such as what Lucy was talking about there, you know, all the predisposing, precipitating factors that you're thinking about, why it best fits this diagnosis. I think this is a good example where someone's coming to you with an established history of bipolar disorder, and the tendency could be to say, this is what it must be, this is the diagnosis. As Lucy's kind of illustrated there, there's always some ambiguity, but about whether this is definitely the diagnosis. And even if you feel no ambiguity exists, you have to demonstrate a breadth of thinking about precise diagnoses. So I would prepare and be prepared to let them know precise differentials and why you would consider those differentials, what aspects of the criteria do they meet, and then be prepared to explain how you would confirm or refute these. And I think have that ready as an answer out bang, because that's what diagnosis is all about. Things that you can always do are further collateral information, a longer period of observation, a urinary drug screen. And I think that those are things that, even for someone like this, where it seems kind of cut and dry, she's got bipolar affective disorder, it's worthwhile getting. The other points that I would say about this is that we're doctors, so it's always incumbent upon us to be aware and ready to include organic or medical issues. She was kind of ripe for that because there was obviously alcohol use and, you know, some objective, or sorry, rather subjective complaints about cognitive function. So I think it's worthwhile, you know, no matter what your presentation is, saying, listen, I'd always think about organic possibilities. Be precise, don't just say organic. There's a really good medical mimics that's available on the Moodle there that gives you some ideas of organic conditions that are really broad spectrum. Things like, I guess, thyroid function disorders, that if someone's suffering from, you know, any range of anxiety disorders or mood disorders, you gotta have a think about whether they could be hyper or hypothyroid. And I've had instances where we've missed that, actually. The other thing I would say about that is that you guys have got so much more recent experience of medicine. and you can come across quite expert in talking about how you would include or refute that, which is very impressive in terms of you're being a doctor and you're displaying independent thinking. The other two things to think about, maybe not so much in this case, is that just to think whether you can include this in your differential diagnosis, is that trauma-related issues are increasingly prevalent in diagnoses rather than just the formulation. So diagnosis of complex PTSD. Don't throw it in there if it doesn't make any sense. But if it does, if there's a possibility that, you know, is there trauma in the background? Do you want to have a look at the criteria for things like complex PTSD, and say how you would include or exclude that? Could be risky, but it's something to think about. Formulation will cover a lot of their developmental issues. Just have a think about whether there could be an Axis 2 diagnosis as well. Again, possibly not very apparent in this case, but just for a lot of you, it's just something to, when you're formulating and preparing an answer about diagnoses, maybe have a look at them, see can you do they fit the criteria for any of those diagnoses? It would just come across as impressive, I think, you know. So, any questions about that? From all of you, I guess, because all of you are going to have to present diagnoses, right, for your formulation. So you've got to start thinking about how am I going to answer that question. Anything about your, you know, that I can't answer specifically about your case, but anything about how you're going to structure that answer that people want to ask?
I guess I was just unsure on how much to like include, like how many differential diagnoses to consider and how much depth to go into them. But it kind of makes sense of what you're saying with like listing the like symptoms and, you know, the criteria like in the DSM, and this is why it supports it or not. Yeah.
That's a good question about the degree of how depth, because do you start throwing out all these random diagnoses because they had one symptom of, I guess it's about having a few. I think your approach there was quite reasonable, was that, you know, listen, I've taken a history from this person and these are all the formulation that I've got here. It fits a bipolar depressive episode. What about unipolar depression? I should think about that. And what about alcohol? What about a movement disorder? I think that you've covered a good range there, and having a few to start off with and showing your thinking process is very reasonable. What I guess what I'm getting at is that in your formulations, there's always going to be some ambiguity. There's going to be some points that you could pick up and say, so be reasonable about it. I think that the diagnoses that you were suggesting were reasonable. So don't feel the need to be exhaustive, but have a critical mind about this, you know, and apply your judgment, like you would do if you were a doctor, which is what this is about, you know. No other questions for that? Okay. Well, anyone else want to have a go at just reading out your formulation? And I want to ask you some questions about risk. Yeah.
I can try, I guess.
Gisela, yeah, cool. Thank you very much.
Yeah. Let's see. Okay, so AL is a 19-year-old Maori and Pacifica wahine who presented with a 4-day history of increasingly erratic behaviour, auditory hallucinations, violent threats to family members, delusions about being pregnant despite having a contraceptive implant and a negative pregnancy blood test, and attempt to self-harm via overdosing with 4 tablets of her grandmother's nortriptyline. This occurred in the context of substance abuse. AL has a genetic predisposition to mental health conditions, with her mother having bipolar affective disorder and her grandmother having schizophrenia. AL likely has an impaired attachment with her mother due to the impact of her mother's multiple deteriorations of her bipolar. AL described experiencing childhood neglect from her maternal family that affected her physical health. Her coping strategy to emotionally distance herself in relationships with others, showing limited trust in others, and quickly removing herself if a relationship shows signs of deterioration, likely stems from her insecure attachment. This coping strategy has further been strengthened by living between 3 households during her childhood and the abrupt disappearances of her father at age 9 and of her maternal uncle. Evidence of this coping strategy can be seen in her attempts to form friendships at school and the multiple brief relationships she had with others via Tinder. AL describes having 2 close friends in her life, of which she is still in contact with one. The shock of discovering that her father was not biologically related to her during her childhood not only affected her attachments to others, but also negatively impacted her self-identity. AL knows that her maternal iwi is Tuhoe in Te Urewera, but has minimal knowledge about her paternal ancestry. Her grandmother is part Niuean and part Asian, and from a commercialized genetic test, she discovered that she was also part Samoan and had Irish ancestry. Whakapapa is an important part of self-identity in Māori culture, and growing up in Parirua away from her marae and iwi may have caused some underlying distress. AL herself has a past psychiatric history, having been diagnosed with probable ADHD at age 9. AL never received treatment for her ADHD, and she experienced ongoing difficulties with school and making friends, although she was able to pass her science subjects until year 12. In year 13, she gave up her dream of becoming a psychiatrist and played truant for half of the year due to a breakdown. AL did not seek treatment or help from mental health services for this, but did attend one appointment at the end of 2020 where she was diagnosed with depression. However, she did not take the fluoxetine she was prescribed and instead managed her low mood and anxiety with substances, alcohol, marijuana, and psychedelics. AL also used these substances to suppress her upsetting childhood memories. In the days preceding her admission, AL consumed a lot of gin and marijuana and also attempted to overdose with 4 tablets of her grandmother's nortriptyline. Fortunately, AL has a very close relationship with her boyfriend of 10 months and also with her grandmother, and they will help in her recovery from her first episode psychosis. AL is high functioning. She is employed and is attending a culinary course. They're important protective factors for her. AL will be discharged to a community mental health team that will support her in her recovery. And that's the end of my formulation.
Can I just say, the bit that I always worry about is cultural, social, and psychological issues and getting people to talk about that. But you both have already prepared really, really comprehensive answers for both the 2 formulations we've heard, with cultural and social and psych. In fact, you're both like using kind of psychological theories there in terms of attachment, which is what the advice that I was going to give was, just to have some basic, but that's really good. So listen, and again, yeah, I think that formulation is following the structure really well. So I think that should be fine whenever you've printed that out.
Thank you.
Continue to work on it though. But listen, can you please describe the key risk issues associated with this case?
So she's got her biological risks would be her family history of bipolar and schizophrenia, and in terms of her more predisposing her substance use and biological and psychological effects of that. She is she's got her other psychologically, her insecure attachments and the subsequent effects on relationships to others. With that, she's very dependent on her boyfriend, which is a protective factor at the moment, but there's always the concern that that could be too much of a dependence. And we've never really talked to the boyfriend, so we don't have that perspective from him about how their relationship is like. There's the cultural aspect with her not knowing much of her self-identity, and that she has been quite fixated on that point during her admission and discusses that quite frequently with us.
Can I just stop you there, Gisela?
Yeah.
Because I think what you're driving at here is that you're talking about the various different biopsychosocial
Yes.
risks or kind of predisposing things for mental illness. What I'd like you to talk about is the key risk issues in terms of pragmatic real world risks of adverse events.
Okay. So sort of like, you mean suicidal and homicidal risks, or?
Just what are the key risk issues? Yeah.
Okay. So she's got ongoing psychotic symptoms, and they do distress her. She doesn't have any suicidal ideation at present, so that is a protective factor, and she's a female, so that's kind of another protective factor. She has, and going back to the suicide stuff, even though she's attempted to self-harm with 4 tablets of nortriptyline, isn't going to be a serious suicide attempt, I guess, is, and the other threats that she's made about trying to kill herself wouldn't cause her to actually kill herself, such as vaping, or she said doing a harsh vape one time, that kind of thing. So I don't think she has any serious plans for suicide. She still has ongoing hallucinations, but none of them are commanding, and aren't threatening, telling her to threaten herself or harm herself or others. In terms of risk to others, she does come from a background of some of her maternal family members are gang members, and also her previous substance abuse. But she's currently in the ward. There's no that she feels safe on the ward most of the time. She did feel that her personal space was being invaded a couple of days ago, and that was causing some distress, and she threatened to but we've responded to that and mitigated that, and she's feeling safer now. And she hasn't had a previous forensic history. That's kind of all the risk factors I can think of. Sorry, that's all over the place. But yeah.
Yeah, no, I think having a bit more of being prepared to be asked about that is a good idea. And having a bit more of a structured approach to the headline risks with this person. And we're going to talk about it in a minute, but then making sure that you're displaying, as you did, actually did as you went along there, you started to display that you're thinking about all the other risks and the relevant negatives. But I don't think you need, I think I think that if you're answering that question again, it's coming in with quite a snappy, here's what I've identified as the main risks and here's why. And, the static and dynamic factors for all the other things aren't really leading me, but I have considered this, and this, and this. And maybe there's this, I think that the headline news with her is really suicide risk, because as we're going to talk about now, dynamically, there was a recent kind of, I suppose, overdose that we know to be low lethality, but is I suppose an important thing about there is about perceived lethality, ongoing suicidality, and I suppose dynamically the fact that she has ongoing symptoms of psychiatric illness, which you're kind of getting at. So what you could say there is that in actual fact, in terms of absolute risk, you might be right, but maybe her dynamic suicide state is a bit above her personal baseline, and should be considered, I think, in someone like this. Does that make sense?
Yeah.
I think maybe if I just pull up my slides on this and we'll think about how these pertain to your case, because I think that everyone, when we're answered that question, should be thinking along these lines and be able to kind of provide a good succinct answer. And so I think that whenever you're presenting your gathering your facts about risk, the focus should be on showing that you've thought about everything, but you also have a focus on the salient thing. So I think the way to do this is to think about it in terms of static issues and dynamic issues. So I'm sure you can probably all outline to me what static and dynamic issues are, but I'll just go back through them again. So static issues are unchangeable factors that statistically alter their likelihood of a specific adverse outcome. So that's often previous behaviors that they've engaged in, previous diagnoses, or demographic factors. I guess also there's an extent to which, as you've kind of talked about there, socio-cultural factors are quite static for someone in terms of, say, risk of violence to others, which is what you were driving at there. I think that probably the most important thing not to miss is dynamic issues. So there are current pragmatic issues or deviation from their static norm that indicates an adverse incident might be more likely. And also the other thing to do is that static and dynamic is mitigating factors as well, which you kind of started to get into now. So the way I would structure it is that you identify the salient positive risks and the static and dynamic things that are contributing to it. Bam, give that answer. And then also, as I've kind of said, give some form of acknowledgement that you've considered other relevant negative risks without getting too bogged down in it. And I would consider developing a single statement, just saying, here, listen, I've thought about these things, and there may be one or two dynamic or static issues to identify there, but they're not currently salient. And just in terms of the different things to think about, whenever you're preparing your answer, I would keep this as a mental checklist. For 90% of cases, I think you'll probably agree that the salient headline risk is probably self, and it's usually self-harm and suicide. And I feel like it's probably the most area I'll feel most confident on discussing static and dynamic risks for. But don't forget to just check with yourself about neglect to self. So static and dynamic problems with neglect, static and dynamic problems with misadventure, reputation for people with bipolar affective disorder, then falls and medication related harm. I think you were also starting to Gisela, to get into this, but it's good to have this prepared, that risk to others, so physical violence, fire setting, driving, from others, so violence or exploitation, other general vulnerabilities. What I'm really like, this is a checklist, right? I don't expect you to sit down and list out your answer and just go, for this, it doesn't have risk. I think if you have a succinct statement after you've talked about the relevant positive factors or relevant risks, and say, to just illustrate that you've thought about all these things, to bookend your answer, that would be a good way of communicating your thinking. Does that help you, Giselle? Does that help you think about how you would structure that answer a bit differently?
Yeah, I think, kind of like I would do a general summary statement and then go through the positive factors why, and then just briefly kind of say.
Am I right that with her, the headline news on this presentation is that there's a dynamic change in suicidal risk factors? Is that correct?
Yeah.
Yeah. And someone that already has some static factors, she's had mental health problems in her childhood.
Yeah.
We know that confers you an increased risk of, or she's engaged in self-harm before. Are there many other static factors that increase her likelihood of suicide?
To be honest, I don't think there are many other static factors that it's just
her ethnicity.
I guess Maori.
Which is a huge static factor, and remember, static is things we can't change that are statistically change your likelihood.
Mm-hmm.
So it doesn't really, you don't go treating someone's ethnicity, but it's just, it just informs your assessment of risk, I guess.
Yeah. I'm just wondering, what do you mean by misadventure?
So I guess misadventure is accidents. Accidents will happen, What I'm more thinking about there is that if what you might find is that, say, if you're presenting someone who's presented in a very psychotic state, who has command hallucinations, who has gross thought disorder, who is not necessarily describing anything suicidal or volitionally suicidal, or is not neglecting themselves, but might be at risk of accidents due to their disorganized behavior. They may be at risk of irritating or upsetting people in the street and getting punched or beat up, or it's more gross misadventure. And listen, I suppose that is a risk to self. I suppose that does it does start to blend the boundaries with risk to others, because misadventure can be something that you inflict upon others as well out in the community. It doesn't sound like it was a particularly salient risk with this young girl. It sounds like her behavior was organized, and that there was no real static issue suggesting that she's someone that gets on well and goes off and behaves chaotically. My thinking about that is that, say, for example, someone with psychosis, who in the past, whenever they've been unwell, has tried to break the windows of a shop, and has gotten beaten up as a result, and is now becoming psychotic again, and is thinking that he's being monitored by cameras inside shops. That's a combination of static and dynamic risk that makes misadventure high. And that would be salient headline news for whoever that person is, but not for your case. Can I ask, just for everyone else, is that a clear enough approach to risk? Is there anything that you wanted to add to that?
I just had a question about what the reputation part meant.
Yeah, so like, I think reputational risk is something that I look at. It generally comes up more likely in people who have bipolar affective disorder, who, by virtue of their dynamic symptoms, or their symptoms perhaps, or their behaviors, they're dynamically at risk of reputational damage, say in their business dealings, in their so there's financial and reputational, I suppose, risk encompassed in that, but also, I guess, in terms of their behavior amongst their social circles. Sometimes you can find that a dynamic risk of reputation increases because of mental illness. That is a niche one. It's not something. It's generally not headline news for most cases that you're going to be dealing with. And if you are preparing a little short statement that outlines the relevant negatives, you don't necessarily need to say, oh, there's no reputation risk. You could say, listen, there's no other major risks to self, such as neglect or misadventure, nor is there any identified major dynamic risks to others or from others, such as violence to others or exploitation. Short, snappy little sentence that you can prepare to say that I've thought about all this, I've gone through my checklist. But it's also important, whenever you're preparing your formulations, to think about these things. Okay. Now, there is a second part to risk that I just wanted to just expound on, because, listen, I think that identifying risks is a history-based task. Risk, what you do about risks is a bit more complicated and probably comes with experience. It's a difficult thing to do. It's a difficult thing to know how to identify salient suicide risks, and then what do we do about it? Just so you know, I mean, increasingly clinically, what I'm being taught to do is to move away from, identifying all my risks and saying they're high risk of suicide. Because I think what you find is that actuarially, we're actually really bad at doing that. But rather is what you do is you take all the factors that you've identified and you think, what are we going to do about that? So what the buzzwords that we kind of use now is that you formulate co-produced plans to mitigate risks. So I know that in the Moodle stuff, there's a million different perspectives on this, but what the DHB, the MHID's training on risk formulation and management, and in other jurisdictions that I've worked, they look to this guy, Anthony Pisani. If you see that reference there. So it's from prediction to prevention. And it includes, in your information gathering, it also likes you to look at the person's available resources. So do they have people around them? Do they have a good support network? Are they well linked in with community services? And also foreseeable changes that you can act to mitigate. I think that if you were asked the question, can you describe the key risk issues? And you were able to just preliminarily suggest some sort of risk mitigation strategy, which you were actually starting to kind of do there. Is that you were talking about the fact that, listen, we're treating her symptoms. I think looking at her available resources are that the minute she's in hospital and she's been treated for her symptoms, so we're mitigating those risks. But you could also say that, in the long term, she's got supportive whānau, or, I don't think you necessarily need to do that, but I do think that would be impressive to show some degree of planning to mitigate identified risks. Anyone want to ask anything about that? No? Cool. Okay, so listen, that's all I have on risk, and hopefully that'll be helpful in answering that question. I want to move on to another topic. Is anyone everyone else is a blank screen, so I can't see any of you guys. So you'll have to do more than you'll have to switch on your screen if you want to volunteer. But I was hoping to get someone else to read out their formulation, and we can do some questions on it. Felix, you switched on, so I presume that's volunteering, is it? Yeah.
Yeah, that was terrible timing.
Yeah.
Okay. Yeah, I can go. Do you want me to share the screen so you can all read it, or maybe it's just me that finds it hard to read it? Listen, sorry. But it's all good. Okay, so Mr. G is a 62-year-old man who has a 30-year history of well-controlled schizophrenia and has had interactions with mental health services in 2001 and 2015. Mr. G required admission to NRR, which is the inpatient unit in Hawke's Bay, on the 27th of September and required police assistance. Following concerns of increased paranoia over a 2-month period and suspicion of throwing a rock through a friend's window. Police were asked to intervene following poor interactions with mental health staff and were required to enter his home. And it was a recurring theme in Mr. G's current dialogue. On admission, Mr. G was appropriately dressed with suboptimal self-cares, engaging well, albeit with a slight irritability. His speech was rapid and rate with normal tone and volume. He did not comment on his mood, although objectively he appeared euthymic with a slight labile affect. His thought form was circumstantial with episodes of tangentiality, was subject to referential ideas and most likely abnormal perceptions, particularly with cutting down of gum trees, people breaking into my house, and spirits in his house at his home in Otago. His cognition appeared grossly intact. He retained insight and judgment of the situation. 2 days later in consultation, he presented similarly. His non-bizarre ideas of reference persisted, although today were purveyed in a predominantly linear thought form. Mr. G was previously managed with olanzapine palmitoate long-acting injectables. However, he had not received an injection since late July, evading health services. Since readmission, he had been restarted on olanzapine 10 milligrams oral formulation. Mr. G's upbringing and family dynamics are very much unknown. A recurring theme in his notes dated back to that date right back to 1995 is that no family had been present or involved in his care. There is no known family history and no next of kin documented that are contactable for further information. There was an indication that his father was a heavy drinker and user of cannabis. Further, a brief comment made in an old note referred to his disappointment that his family, presumably his siblings, had left him in Ortane when his parents had died. Mr. G lacked parental role modelling and likely learnt poor coping mechanisms to stress by observation during childhood and adolescence. During adulthood, he has been devoid of family support and belonging, and therefore he has some predisposition for mental illness. We discussed his poor interactions with healthcare staff, police, and other local figures of authority over recent years. He has poor access to healthcare and describes his 6-hour return trip on pushbike to Waipak from Otago, which is like the local town. And so he has to do that fortnightly for his olanzapine depot. These experiences have likely caused the development of his dismissive or self-reliant attachment style. This is a probable precipitant to his recent non-adherence to treatment and poor interaction with healthcare staff. He has a long-standing history of cannabis use and mild alcohol use, but he says this has decreased recently. From a psychological perspective, a number of changes occurred in Otago that were at the centre of his referential ideas and may have contributed to its regression. He took particular offence to the cutting down of the gum trees, new townhouse developments, and destruction of a local tennis pavilion in the area he is proud of, and says there is nothing for me to go home for. Collapse of a relationship between himself and a friend, as well as being unable to attend a local service user help group in Otago due to unclear reasons, are all perpetuating factors to Mr. G's current presentation. He retains reasonably good health apart from a diagnosis of COPD 8 years ago, although he's recently adopted although he has recently adopted a reclusive lifestyle. He continues to bike for hours and shops at the local dairy daily. He has responded well to psychiatric treatment in the past. Mr. G has a supportive and involved outpatient care team and typically has good interaction with a support worker. Mr. G's current acute psychotic presentation is most likely a result of persistent non-adherence to his olanzapine LAI, leading to a relapse of schizophrenia. His overreaction and ideas of reference around current events in Otago are most likely to be a result of his florid psychotic state, but it may also be a re-traumatization of poor parental role modelling and involvement and abandonment by family in Otago during adolescence. This may have resulted in his reclusive state, and given the challenge of cycling to Waipak to access healthcare, has distanced himself from mental health staff, resulting in non-adherence. And that's it.
Okay, listen, I think that's listen, you're very much following the section 1, section 2, section 3, I feel, from the formulation guidelines there, and a very detailed section 1 as well, giving us a sense of his mental state exam, which I don't think you necessarily have to do, but listen, I don't think it's a bad thing to include it either, because it gives us a good sense of the predicament, as they say. So listen, again, I think that you've done well in kind of throughout the second section, so the second more formulating bit, touching in and out of cultural, social, and psychological issues. But can you give me a succinct answer to this question? Can you explain the key cultural, social, and psychological issues associated with this case?
Yeah, so we'll start with psychological. I guess one of the big things was his lack of coping mechanisms. So he didn't have any positive role modeling or anything growing up. His dad being a big user of alcohol and cannabis, and the fact that he left him at a young age all meant that he would have developed sort of maladaptive coping mechanisms, and having poor stress responses to stress. And obviously just modeling an environment of alcohol and drug use. There was a vague traumatic history from his upbringing, but it was sort of not very detailed. But this sort of made him more prone to bursts of anger and mistrusting others and that sort of thing.
Well, when you say a vague traumatic, how is there any other trauma-informed kind of hypotheses that you know that kind of fits that bill, or?
What do you mean?
So you've talked there about psychological. You've talked about essentially deprivation in a psychological sense, insofar as that it didn't have good carer relationships or role models.
Yeah.
And then you've kind of flitted around the idea of trauma. Have you read up?
Yeah, right. Like a PTSD or something like that.
I suppose some people do talk about small T trauma, don't they?
Right.
Or complex PTSD. Is that fair to say?
Yeah, it's not something I'm familiar with, but it sounds fair to say. Yeah.
Yeah. Okay, keep going. Yeah.
That's cool. And then I guess he's got a negative and distrusting view of others, and so that was sort of related to his dismissive and self-reliant attachment style. He's got poor emotional regulation, which has been especially evident recently on the ward. And he just has a lack of support and appropriate responses for when he is distressed. I guess from a psychological point of view, that would be the main thing. From a social perspective, he does actually have quite a good social network and support. So his social work is really involved with his care, usually, apart from when he sort of went AWOL and stopped attending the clinic. He's got one friend who he's close with, who's recently he's parted ways with, and the support group, obviously, that he's no longer able to attend for one reason or another. He's unemployed, doesn't have any he lacks direction, focus, and just like goal-orientated lifestyle. And he's got a bit of an environment that surrounds him in drugs and alcohol, obviously perpetuating his condition. And then culturally, I didn't delve too far into his culture, but he's a Māori fella, so it probably would have been good to delve further into his culture and stuff, especially around that, given that Māori do have some sort of common theme of hearing spirits and sort of dead people along their genealogical line. And that's probably relevant to him with the spirits that have been in his house and we're trying to evict him. But I guess, I'd probably want to explore it further and see if they'd want to be, I guess, some use in using like Māori liaison services. But otherwise,
I think so. There's a lot of good points there. I think that one of the key elements of answering this question is that I think the rest of the questions that you're going to be asked about formulation are generally quite factual and require quite a cold approach in some respects, insofar as that you're going through lists in your mind. I guess this is a chance to be a bit more empathetic, and maybe having an empathetic tone and a sense of kind of interest in the person, I think will go a long way to helping with answering the question. I think just be careful, because I think you said that you thought that he had quite good social circumstances, but then you paint a picture of someone who you're thinking about the very relevant things. You're thinking about his friend networks, his access to positive social experiences. The other thing you talked about was the fact that he lives and he has to travel on a push bike.
Yeah.
To get anywhere.
Yeah, he does. He said it's a 6-hour round trip from where he lives to the clinic for his depot. So obviously, he had poor access to healthcare, but the healthcare that he does have access to, he does have a good relationship with. That's
right.
What I'm trying to say. But yeah,
that's a great way. That's a great way to put that, and that's the kind of thing that I would be saying, and I'd be just thinking. I'm thinking about him empathetically, and what is this guy's life like? Which you're obviously doing, but I think it's just having
it properly.
Yeah, and I think that being respectful of and definitely diligent about exploring the cultural aspects.
Yeah.
I think having an answer prepared that reflects thought around that before you go into the room.
Yeah.
And explore some of the what you do know about his cultural circumstances is important, and I wouldn't leave it to speculation. If you're in there, I think psychologically, yes. I think when you're being psychological, you can definitely be a bit more succinct, like you were.
Yeah.
But I think social and cultural factors. You do also need to be precise and have a well worded answer. But it's a chance to be a bit more empathetic about the person.
Yeah, okay.
Yeah, and just be cautious about about contradicting yourself and saying that, because he does sound like he does have he struggles a bit with the social circumstances. So just by way of my little points, and I think that from what I've heard from all of you, you've already probably all got a really good answer from this. So I kind of felt that with sociologies, it's a chance to show some common sense thinking about the person and about how they are in the world. I would say common sense and empathetic thinking about the person. a quick checklist of the key social environmental factors that have influenced them in getting to where they are now, and also any current perpetuating social factors which you've obviously done. I've put there that psychological issues are tricky as you're only really getting teaching, but you all seem to have, I mean, like you've all talked about attachment styles, you've all talked about early life experiences impact on attachment styles. You've even gone so far as to talk about dimensions such as emotional regulation. And we've talked there about maybe you're even starting to think about trauma. So what my advice was maybe to be familiar with the principles of one or two psychological theories and be able to provide some understanding of how they can be a prism to, so yeah, attachment theory seems to be, the one thing I would say to you all is that maybe don't go in and answer a question with about and base your answer on attachment styles without knowing something about attachment theory. Maybe have a quick read, and or if you want to talk about early life experiences as they pertain to CBT, you know, core beliefs about themselves. Just have the Oxford Handbook of Psychiatry does a good little summary of the core ideas of psychological psychodynamic therapy, or the psychodynamic model, the CBT model, attachment model. So just if that's going to be your response to a question about psychological issues, maybe be able to, you know, again, I'm not an examiner. If I was an examiner, I'd want to ask, so tell me a little bit about attachment theory there, you know. Do you, I mean, like for everyone that's already answered the question, I must admit I'm not massively up on attachment theory. Do you know much about it? Okay. So I think whenever you're describing attachment styles, just make sure that it fits with a recognized kind of theory of attachment. Because I think that's an opportunity to be somewhat precise, you know. Or if you wanted to say that, listen, you can understand this through a CBT prism, that CBT prism is that people in their early life experience develop core beliefs about themselves. Or, you know, if you want to talk about the style of defenses they use, that's psychodynamic theory. And just have a read and make sure that you know what you're talking about. Within reason. You don't need to be an expert, just the basics of how these theories works. What are the attachment styles described in attachment theory? Does that make sense?
Yeah, that makes sense.
Okay, so listen, for psychological, social, cultural issues, you're all pretty up on that. I think that tip about psychological is an important one. Being empathetic and pragmatic about the person that you've seen, and how they are in the world is important, because we're a caring profession, you know. So any other questions about that? And you know, I may have made it sound wishy-washy. Like the other two things we've done, be prepared, practice what your answer for this, you know. Okay, so guys, we've only got one question left. So Yulia and Tatenda, either of you guys have something prepared that you might be able to just read out your Yulia, you happy enough to do it? Yeah.
Yeah, I can do it.
Cool, thank you.
Oh, okay, so I've just changed the guy's name in this. So Max is a 12-year-old Pakeha male, admitted informally to Rangatahi unit approximately 3 weeks ago. He presented to ED after an intentional overdose of ibuprofen, Panadol, and homeopathic diet supplements, according to and accompanied by his auntie. He was then admitted to Ward 1 at Wellington Hospital. He presented with symptoms of 1 to 2 months of low mood, low self-esteem, suicidal ideation with planning, and self-harm in the forms of cutting and ligatures. He was seen. He's been with CAMS since June this year for an overdose of 1 pill, and there are reports of family violence, which have led to Oranga Tamariki involvement. So Max grew up with 3 brothers, all of which suffer from time-intensive health issues, one from body dysmorphia and eating disorder, one from difficulty managing emotions, and the youngest has been diagnosed with Down syndrome. Because two of his brothers exhibit some kind of mental distress, there may be a genetic component associated, and Max may therefore be predisposed to developing some kind of mental distress. A number of stressful events have occurred throughout Max's childhood, which could have contributed to predisposing him to the mental distress he is experiencing. His father was an authoritarian figure who used verbal and physical abuse to show his anger when things weren't done the way he wanted. This has likely contributed to Max's low self-esteem, as well as developing negative coping mechanisms as a result of negative parent modelling. As his mother has 3 other children with time-intensive conditions, this may have caused Max to receive less of his mother's attention throughout childhood, which may have predisposed Max to feelings of low self-worth and perpetuated his low self-esteem and feelings of being unwanted. As a result of Max's father's parenting style, Max's mum developed a soft-touch parenting style with loose rules. As a result of this difference in parenting, Max could be predisposed to forming insecure attachment. As his dad continued to live with the family and submitted Max to consistent abuse, this oppressive environment may perpetuate Max's lack of coping mechanisms, low self-esteem, and self-worth. This could therefore result in feelings of low mood, powerlessness, and feeling small. Mixed with Mum's constant divided attention and his lack of coping mechanisms, this could have precipitated suicidal ideation and self-harm as a way to force attention and care. It seems that arguments with Mum and her taking the brother's side on arguments perpetuates the insecure attachment Max may have developed, and in turn precipitates the suicidal ideation and self-harm as it solidifies feelings of self-worth. Since his stay at Rangatahi, his father has informally left the house after guidance from Oranga Tamariki. Max has been on a number of home visits, which he finds distressing due to bad memories resulting in re-traumatization. Max's core beliefs of worthlessness are continued to be precipitated by his mother's inattention. Although Max has good engagement with mental health services, this may be seen as a protective factor. It also seems to perpetuate negative connotations of home. Due to Max's age, he receives one-on-one care at a Rangatahi unit, satisfying his needs for attention. However, when this is removed, he reverts to feelings of low self-worth and self-esteem. Protective factors for Max include some of his family members and friends that he has outside of the unit. He also does not use drugs or alcohol as a coping mechanism. So that's it. Why can't I hear anything? I think you're on mute.
Sorry, I wasn't saying anything important anyway. So, what I was saying was that it's very interesting formulation, and I think that from your perspective, if you were answering questions about social and psychological issues, there'd be a lot to talk about there. And again, you've talked about attachment, you've talked about parental modeling, and his behaviors. Is there any particular model of psychological understanding that you applied to that case? Attachment.
What did you say?
Any particular model of psychological understanding that you've applied to that case?
I don't really know what that means, to be honest.
So I suppose whenever you've provided like a really good formulation of how someone's experiences in childhood and their experiences in the family home and the systems that they're exposed to is affecting their behavior now.
Yeah.
Any kind of I think if you were presenting that, it'd be a good opportunity to talk about psychological models of understanding, theories that could explain that. Is there anything you've looked into, or?
Not particularly, no.
Just he's pediatric, isn't he?
Yeah, he is. He's in the child and adolescence unit.
So I think that a lot of the time for the psychological kind of theory that they use for understanding children is it's all very systems.
Mm-hmm.
So systems therapy and things like that, and family therapy based.
Yeah.
So it would be interesting to look at that case in that prism if you're preparing an answer. But listen, can I ask you this question?
Sure.
Please, can you detail your management plan for this client?
Yep. So I guess I would kind of break it down into biopsychosocial and kind of look at acute and long-term management strategies. So for the biological, initially I would start him on some kind of SSRI for his low moods, potentially fluoxetine as first line, starting low at about 5 milligrams and then kind of titrating up. If I feel like it's taking an effect, I would obviously monitor any side effects of that and try and mitigate any side effects. So for things like GI upset, if he has, like, making sure he has a high fiber diet and good fluid intake and all that kind of stuff to reduce the chance of things like constipation and diarrhea. And then if he is constipated or anything like that, we can add in some laxatives if it's necessary, or just give him some Kiwi Crush initially. For insomnia, could give him some pear and melatonin. Prior to starting fluoxetine, I'd do a baseline ECG, just so we have that on board, and just watching out for things like serotonin syndrome. And then in long term, I'd continue the fluoxetine if it was effective, and I'd be mindful of future psychotic episodes, as it may indicate a bipolar picture, and then might have to change medications there. In terms of psych, so initially would want to admit him to rangatahi, which he already is, for a 24-hour watch, and reducing the chance of a follow-up suicide attempt, and managing any suicide risks by removing anything that he can use for self-harm, and also educating Max and his whānau about his symptoms and the potential medications that could be used. In the medium to long term psych management, so you can start with some individual therapy. So as you were saying before, using CBT to assess the negative thought patterns around his self-worth. Some trauma therapy, I thought maybe something like EMDR could be helpful to address traumatic experiences. Some family therapy to address the abuse trauma, as well as reverse some aspects of the insecure attachment that he has developed, and also creating a wellness recovery action plan to develop personal awareness, some skills, and some skill strategies and some goals. And lastly, some social management things to consider, to encourage him to participate in activities in rangatahi, so things like outings and the skill therapy sessions, eating well and physical activity. Encourage overnight leave home without the father present to make reintegration back to home easier. However, if that's not able to happen, consider respite care or a foster home initially as an option before reintegrating back home. And also assist with the family connection through a social worker and oranga tamariki, and then finally just to reintegrate him back into school.
Yeah, that's a good broad depth of thinking. I think that you're right to have biological, psychological, and social aspects. And I think that you're definitely right to explore the pitfalls of suggested interventions such as the SSRI. I might just provide some critiques as well, but I just might just go back before we do that and just say, what is there? Did you have a preferred diagnosis for this person?
So I personally think that he meets a lot of the criteria for PTSD, and my differential would be a first major depressive episode with insecure attachment, but we don't really know at this stage.
That's really good. It's really good to know that, because I think that then that makes something like making a suggestion such as EMDR much more justifiable. Insofar as that, I think that throwing out EMDR as a psychological intervention, which has got a very narrow evidence base, you need to be careful about that, I guess. I think that listen, my advice about this. Well, just coming back to you to your descriptions. Okay, so why fluoxetine?
Well, I think because it's like first line, and
first line for what?
For like depressive episodes. So for depression, I guess. And because of the low mood he's had for a number of months prior to this, I think it could be worth giving it a go to see if it will help. But yeah, it's kind of tricky because he doesn't have depression clinically. So it's kind of like a guess as to how we can help him kind of at this stage, because it's not clear what the diagnosis is.
Yeah, I think again, having a very clear rehearsed statement, and it's gonna flow from diagnosis. That's the first bit of advice I always give, is that the start off with management flows from diagnoses, because managements are supposed to be evidence based.
Yeah,
that's the whole idea of diagnoses. So, and again, you've got time to research and prepare. So if you're presenting, like, say, a formulation of differential that says PTSD is my number one, pediatric PTSD, but I also would consider depressive illness as a differential. Then you flow it on. You say, listen, I've looked at the guidelines for treating trauma-related conditions in pediatric populations, and they say the number one evidence-based treatment is this. So I would use that.
Yeah.
I rather feel like you're suggesting fluoxetine, and I might be wrong, because that's what they've done in the ward. Is that?
So they actually used escitalopram.
Oh, did they? Okay. Well, good. So what was your rationale for suggesting fluoxetine? Because you'd looked it up, had you?
Well, I just thought, it's first line, so I was like, it'll be the best one to start initially, and if it didn't work, then use something else. But yeah, first line for depressive episodes. So yeah.
I think having that really clearly, if you're asked what is your management plan, I'd be very clear about, listen, this is my diagnosis, right? And this is what I feel the diagnosis is. And I've looked it up. And given exactly what you've said, is that, well, first of all, I would say what the first line treatment for PTSD is. And what you might find is that there's a specific SSRI that's recommended. And I think that'll be a very impressive suggestion. And then talking about the relevant pitfalls of it, I just be very clear on the side effects of an SSRI. Just I would, in a pediatric population, don't ever forget to mention the increased risk of suicidality.
Yeah. Did I not say that? Yeah, fair enough.
Yeah. And what are you using as your source for listing the side effects?
NZF. Yeah.
Brilliant. Excellent. Like, being able to say that, but say it confidently and just say, listen, in NZF, these are the side effects, these are the things you got to look out for, because that's what you do as a real doctor, right? Apart from that, I think that was quite a reasonable. I think for this case, it sounds like psychological and social interventions are quite well linked, and you're making a lot of suggestions there. I think emphasizing the role that supportive organizations to help families.
Yeah.
Because this is really a systemic presentation, is it? It's this child is upset because they're finding that their family system causes them distress and distress.
Yeah.
So part of working on this is going to be working on that.
Yeah. Definitely.
And I would tailor your answer that really front loads that and shows a real good understanding of that.
Yeah.
So listen, I'll run through my suggestion. So I think the best approach is look at your preferred diagnoses and do some research about the best frontline evidence-based interventions. Have that really well worked out, clear, and ready to present as your answer. And prescribing guidelines such as the formulary is a good thing to go for. The NICE guidelines or the RNZCP website are good ideas. You can also use things like the Oxford Handbook has a lot of good advice about management. The Maudsley prescribing guidelines are really good for medications. You can also talk about the fact that you take MDT advice about psychosocial interventions. If you don't know much about EMDR, you could ask a team psychologist if EMDR would be appropriate for someone like this. Have a good basic knowledge of the interventions, including pitfalls or side effects. You've done that. And have a preferred course of action, but be able to tell the examiner that you have resources and you can guide other biological or psychological treatments if necessary. I think patient preferences and family preferences should be something that you mention. I mean, like what is this child's goals? What are the family's goals about what we need to change to make things better? They're not always practicable, but they show an attempt to effectively partner with the person. And I think that'd be very impressive as part of an answer. Again, I think that management shows consideration for biopsychosocial model. And you've had to think about the social, practical, or environmental changes that it might help this person recover. I think that you could have taken that to become a really excellent formulation. If you thought it's the things you're suggesting there about reintegration through school, maybe if you had to think about how do we really do that in practice, or who does that? You know, do Orang Tamariki have access to resources that provide systemic therapy? I think having a think about the real world way in which you would manage this person, rather than just the hypothetical management, would be really impressive. Does that make sense? Do you think is that practicable? I know that, listen, that might feel like you're very far away from that decision-making process, but as you go through medicine, it doesn't get, no one tells you that these are the resources you have, choose. Sometimes you just got to go out there and figure out for yourself, what does this person need? And I think if you're preparing an answer and you've shown that you're thinking on those lines, that's really impressive. That's really an excellent answer. I think social, spiritual, and cultural. The other thing to do, you can do here is that we've talked about risk mitigation. I've said that that's a high level of response. I think that putting risk mitigation in your management plan would be impressive. And also that, listen, clarification of your differential and general physical health evaluation are always important. So I would broadly say that the response that you gave there was nice and broad and well thought out, but there could be some specific aspects of it that would come across as really much more impressive, definitive. This is my diagnosis. This is the best evidence base for this. This is the problems with it. This person needs these social interventions. And I was thinking about it. I wonder if we could partner with Orang Tamariki to try and seek family therapy for this person. You know, that's a doctor. That'd be impressive. Any questions about that? I think you're just muted.
I don't have any questions, sorry.
Does anyone else have any questions about management or Am I preaching to the converted here? No. Okay. Listen, we've got 15 minutes left, so we only have one person who hasn't presented. Listen, what I think would be better to do is just, in terms of the overall Viva, right? Does everyone have a clear sense of the tone of the Viva and the kind of responses you need to be giving? Anyone want to ask any questions about any of those 4 domains you're going to be asked about?
I actually have a question. In terms of cultural things, when you have a patient that is like Pakeha and just kind of doesn't really have much of a cultural aspect to their presentation, do you kind of just like leave it out, or what kind of things can you talk about?
Like, I don't think you can, like, can you ever say that someone doesn't have a cultural aspect to a mental health presentation? Like I guess, you know, it's not as well codified, but I think that everyone is to some extent a product of their culture. So if you know this person, and listen, there in every ethnicity there are subcultures, right? Subcultures exist that inform how we are in the world.
Yeah. So like, for example, with this 12-year-old boy, some cultural things I kind of thought about were like social media and that kind of thing. Is that something that you would consider cultural?
I think in pediatric populations, the biggest cultural factor, possibly even more than or spiritual factor that comes out, is the role of social media. The pressures of social media, and that, I mean, like, you have to identify that, because that's going to be somewhere where it's like, for a lot of children, you're going to have to intervene there. Like, is there a problem with social media in this child?
No, but I was like, most of my formulations are kind of, because I'm on the peds kind of psych team, so most of them are like kids, and I was kind of just trying to figure out what kind of like cultural things affect children, and the only one I could really think of was
the other thing that affects children is the culture that's embedded in their school. So if it's a high performing school, if you know, you can understand everyone in terms of their cultural and social background, and you know, and there is the argument that there's also archetypes. You know, there's obviously like they talk about the New Zealand male, don't they? The stoical Pakeha New Zealand male that doesn't engage with their feelings. Cool. I guess if you're coming from if you're female, there's a whole cultural milieu that comes along with being female, in terms of, I guess, contemporary and historical expectations of the female role in society. You can talk about things like that, you know, that I don't think you can ever not understand someone as part of the culture that surrounds them, you know. I mean, like, how salient it is and how much of an impact it is, you have to apply a bit of judgment there. But it's worth at least, you know, signposting, I've thought about this.
Cool. That's helpful, thanks.
So I think just thinking about your formulations and being prepared and practicing what you want to say about this person as well, and sometimes even sometimes preparing for something like this, take a step back and think about the person you took a history from and say, actually, what needs to happen with this person? And I think that's often when you'll give the most impressive answer, is whenever you've genuinely thought about it in all these dimensions, rather than just trying to prepare for a Viva, you know. That makes sense. So anyway, I think we'll leave it there.